So hello guys, welcome to Glomus tumor. Glomus tumor is also known as paraganglioma. Paraganglioma. It is a benign tumor derived from paraganglionic tissue, also known as neuroendocrine tissue, derived from neural crest cells, which later migrate along parasympathetic nerve of head and neck during embryonic life. It's a benign tumor, and from it is derived from paraganglionic tissue derived from the neural crest cells. Okay, neuroendocrine tumor. That's why they secrete catecholamines. According to the location, they are called carotid body tumor, which are present at bifurcation of carotid artery, jugulotympanic, dome of the jugular bulb, glomus glomus intervagal, upper end of the vagus. Based upon the site, they are divided into three types: carotid body, jugulotympanic, and glomus intervagal. Jugulotympanic tumor occur either in the dome of the jugular bulb or in middle ear promontory along the course of tympanic branch of ninth cranial nerve, that is Jacobson nerve. Okay, middle ear, and here downside will be the jugular bulb. Okay, and medially will be the promontory. Okay, medial wall. So it can arise from the base, that is jugular bulb, or from the promontory. Okay, based on that it is divided into glomus jugulare and glomus tympanicum. Okay. Here you can see the glomus tumor sites. Okay, here is a carotid body tumor. Another one is a glomus vagal intervagal. Another one is glomus tympanicum and glomus jugulare. Okay, these are the four common sites of the glomus tumor. Here you can see the glomus tumor in the middle ear. Okay, it can spread to the labyrinth. It can spread intracranially, that is middle cranial fossa and posterior cranial fossa. It can spread to the eustachian tube. It can spread to the jugular bulb. Okay, it can come into the extra-auditory canal. These are all the possibilities of the spread of the glomus tumor. Okay, let's start. Okay. Microscopically consist of cell nest, sheets, columns consist of two types of cells, that is in Zell-Ballen pattern. Type 1 chief cells produces catecholamine and vasoactive substances. Okay, and type 2, that is substanticular cells, considered as a modified Schwann cells. Okay, type 1 are the chief cells which produces catecholamines and vasoactive substances. Type 2 are substanticular cells which are considered as modified Schwann cells. Etiology: most commonly in 40 to 50 age group, and it is most common in females than in males. 5 times more common in females than in males. Okay, it is in age group of 40 to 50 years. It is a benign non-encapsulated extremely slow growing tumor, highly vascular neoplasm. Okay, as it is non-encapsulated and highly vascular, there are higher chances of bleeding. Okay, it is locally invasive. Abundance of thin walled of blood sinusoid with no contractile muscle coat leads to the bleeding from the tissue. Okay, it is non-encapsulated, that's why higher chances of bleeding. Glomus jugulare, I said no, two types, glomus jugulare and glomus tympanicum. Glomus jugulare arises from the dome of the jugular bulb and invasion hypotymphanum and jugular foramen, leading to the neurological symptoms of ninth cranial nerve. Okay, that is Jacobson nerve. Compresses the jugular vein and invade in the lesions. Okay, next coming to the glomus tympanicum. Okay, arises from the promontory of the middle ear and produces oral symptoms and sometimes associated with a facial paralysis. Okay, glomus jugulare arises from the base of the jugular bulb, and glomus tympanicum arises from the promontory of the medial wall. Okay, spread of the tumor. So let me tell you. See, this is the middle ear. It may live in the middle ear. It may go down and affect the jugular bulb, and it may move to the mastoid and affect the mastoid. It may go up and go to the middle cranial fossa and posterior cranial fossa. It can go in the eustachian tube. Okay, and it may go to the lungs also. Okay, these are the 6 things. Okay, metastasis. Spread of the tumor: first, it falls in the middle ear and later spread through the tympanic membrane into the external ear or canal. Okay, it may come into the extra-auditory canal and invade labyrinth, mastoid and petrous pyramid. Okay, it may also invade jugular foramen and base of the skull, leads to the 9th to 12th cranial nerve paralysis, palsy. Okay, though through eustachian tube goes to the nasopharynx, intracranially to the posterior and middle cranial fossa. Metastatic spread to the lungs and bones is rare. Okay, I hope you understood by diagram only. Next, coming to the clinical features. What are the clinical feature? When tumor is intratympanic, first symptom will be hearing loss, that is conductive type of hearing loss, and tinnitus, which is pulsatile and swishing character. Okay, Upon otoscopy, you shows red reflex through the intratympanic membrane. Okay, that is rising sun appearance when tumor arises from the floor of the middle ear. Okay, when you will do otoscopic examination, there is rising sun appearance. Okay, rising sun appearance. This is tympanic membrane, rising sun appearance. Tympanic membrane is bluish and bulging, and pulsation sign, that is brown sign, is positive. Pulsation sign, that is brown sign, is positive. So what is brown sign? When the pressure in the ear canal is raised with the help of a Seagal speculum, tumor shows pulsation and then blanches. Reverse happen with the relax of the pressure. Okay, pulsation sign. When the tumor is present as polyp, okay, along with the hearing loss and tinnitus, that is conductive hearing loss and the tinnitus, also shows vertigo and facial paralysis. Okay, also history of profuse bleeding from the ear spontaneously when cleaning is done, as it is non-encapsulated and high large and more vascular structure. Whenever there is any injury or attempt to clear it, okay, there is bleeding occurs. Secondary infection, that is otorrhea associated with CSOM. Otalgia, less common than carcinoma of the middle ear and external ear. Polyp, red and highly vascular, bleed at the time of biopsy and cleaning. Okay, tumor is more vascular, that's why higher chances of bleeding, that they want to say. Okay, cranial nerve palsy, okay, it may, as they enlarge, it may involve cranial nerves. 9 to 12 cranial nerve palsy can be seen, and hoarseness and dyspnea, unilateral paralysis of soft palate, vocal cord, and atrophy of the half of the tongue, that is cranial nerve palsy. Okay, next is audial brute. This is important one. Okay, audible brute, auscultation of the which leads to the systolic brute. Okay, some tumors release catecholamines which cause sweating, palpitation, headache, hypertension, and anxiety. Okay, as it is a neuroendocrine tumor. It secretes catecholamines. Okay, that it causes sweating, palpitation, headache, hypertension, and anxiety. Atrial brute can be heard while auscultation. It follows the rule of 10. Okay, what is the rule of 10? Rule of 10 shows 10% tumor are familial, 10% tumor are multicentric, and some are functional tumors, that is really secrete catecholamines, that are 3%. Okay, 10% are familial, 10% are multicentric, and 3% release catecholamines. Differential diagnosis, that is congenital cholesteatoma, schwannoma of facial nerve, hemangioma of facial nerve, adenoma, choriostoma, aberrant internal carotid artery, high jugular bulb. Okay, these are the differential diagnosis. It follows 10% rule, 10% are familial, 10% multicentric, and 3% release catecholamines. Okay, next coming to the diagnosis. Okay, we will do CT of the head to differentiate between the glomus tymphanicum and glomus jugulare tumor. Okay, next is MRI to determine soft tissue extension of the tumor. Magnetic resonance immunography and angiography shows invasion into the jugular bulb and vein. Next is CT and MRI together provides an excellent preoperative guidance for Pitter's effect lesions. Okay, already said the tumor spreads from middle ear to the eustachian tube to the promontory to the jugular bulb to the middle cranial fossa to the labyrinth, etc. When you will do CT and MRI, it helps to know where is the tumor and what extent it has spread. Okay, so it also helps in doing surgery. Four vessel angiography. Okay, next is embolization and biopsy. Embolization, large tumor embolization of feeding vessel will help in reducing excessive bleeding. Next is biopsy. Preoperative biopsy of the tumor has not done because as it is highly vascular, any misdiagnostic leads to the profuse bleeding. Okay, biopsy is not done as it is highly vascular and non-encapsulated, therefore high chances of bleeding. Embolization is done so to avoid the bleeding. Okay, next coming to the ESR, we will do erythrocyte sedimentation rate, embolization, surgery, and radiation. Okay, surgery is by transcranial approach. If the tumor is small, glomus tymphanicum, whose circumference are confined tympanometry is sufficient. Okay, tymphanotomy. From the from external auditory canal, we can just access the tumor. Okay, extended to the facial recess approach. Okay, facial recess approach. If tumor is small, glomus tymphanicum is extended up to the mastoid and not involve the jugular bulb. Other thing is mastoid neck approach. Glomus jugulare tumor not extended into internal carotid artery, posterior cranial fossa, neck. Okay, next is infratemporal fossa approach of Fisk. Okay, used for large glomus jugulare tumor. Another one is a transcondylar approach. Okay, so these are the different types of surgeries. Okay, so that's it, guys. Here we will end this video. That is a glomus tumor. Okay, there is nothing much to remember. It is a benign, non-encapsulated, and highly bleeding tumor. Okay. So glomus tymphanicum, glomus jugulare. It follows 10% rule. 10% are familial, 10% multicentric, and it is a neuroendocrine tumor. That's why it releases catecholamines. And we will do surgery. That's it, guys. See you in the next video. Jai Hind, Jai Bharat.